The other thing I wanted to talk about, which I think is changing my practice, is geriatric oncology assessments. You know, we've heard at these ASCO meetings for a while that geriatric assessments can help to identify problems and uh, difficulties that patients are getting into if they're over the age of 65. The question is, does that make a huge, big difference in how these patients do? So there were a couple of presentations at the Clinical Science Symposium. The first of them is abstract 12010, 12010 by Denang Lee, who's from City of Hope, where a lot of the geriatric oncology research has been centered. This was a very outstanding presentation. In this presentation, they had patients who were over the 65, 600 patients randomized to getting a geriatric assessment and then getting detailed follow-up by social workers, by nurses, to make certain that any problems in that geriatric assessment were followed up, versus getting the geriatric assessment and all they did was send it to the oncologist. So I'd get the geriatric assessment, assuming that I know what to do with that, but without additional help to follow up on any problems that they're seeing. The results of this, I think, were really very interesting. The geriatric assessment program had a marked reduction in toxicity, a 20% reduction in toxicity, 10% reduction in hospitalization that looked encouraging, but not statistically significant. But the decrease in toxicity means that older patients who are very vulnerable to the quality of life detriment of a side effect, they get fatigue and they're in tough shape. They get problems in eating with nutrition. They get problems in nausea. These things are terrible with them. And the geriatric assessment can predict who's going to get in trouble. So the answer is there are very brief geriatric assessments which you can do. Make certain, if you're an oncologist, you have resources like social workers, like good oncology nurses, advanced practice practitioners, APPs such as nurse practitioners, who can follow up with your patients and make certain that the results of those geriatric assessments are implemented. There was another study that was also done at University of Rochester, which said exactly the same thing. They had about a 20%, 25% reduction in toxicity, and I think all that's important. The paper that just preceded this at ASCO was an abstract on cannabis use. And you know, a lot of these patients that we're seeing are having problems with nausea, vomiting, fatigue, things like that. And this was a very well-defined, first really good study with oral cannabis, combination of THC and CBD that they took versus placebo. So a randomized prospective trial. And the results were very interesting. No nausea, twice as common in the THC group, who took the combination of 1-to-1 THC CBD pills, not under the tongue pills. And they had significant marked reduction, 50% reduction in need for supplemental medications. So this was very important research. There was also another abstract that was published in print only by Subaya, also from City of Hope, E24143, where we were able to find that there was about a 25% usage of cannabis products by our patients. Many times they're not telling the doctor that they're using it, and therefore, what happened to those patients when they were using the cannabis products? They had a 50% reduction in their subjective feelings of fatigue, nausea, low appetite. All of these things were extremely well benefiting the patients that we had. So in the study that was done, that was presented by Grimson as the first author, on the abstract 12008. That study significantly showed that patients preferred the THC CBD to taking the placebo. And this preference shows us that we need to take this kind of information back with us. And if you're in a state which has legalized medication, medical use of marijuana, THC, then this is very useful. Every state in the union is legal for CBD, so that can be taken. But it means that what I need to do now is I need to have more information myself that I can share with my patients on how do you control toxicity, how do you control side effects, both with geriatric assessment and use of an intervention such as cannabis and CBD. So all in all, this has been an important meeting for me in terms of how I change my practice. I'll be sharing that with all my colleagues, and I hope that people who listen here will look up these abstracts, see if it really will change their practice, and discuss those abstracts with other colleagues. This will improve practice generally for our patients, and the more that they benefit, the happier we are, the less stress in our lives, the markedly less stress in their lives.